Hi, this is Tom from ZeroToFinals.com. In this video, I'm going to be going through cortisol and the adrenal axis, and you can find written notes on this topic at ZeroToFinals.com/cortisol or in the endocrinology section of the second edition of the Zero to Finals Medicine book. And you can find flashcards and questions to train your knowledge on this content and help you remember the information for longer at members.zerotofinals.com. So let's jump straight in. Cortisol is a glucocorticoid steroid hormone secreted by the two adrenal glands. An adrenal gland sits above both kidneys in the abdomen. Cortisol is a stress hormone released in response to stress, and it helps the body to cope with the stress. It has several actions within the body. It increases alertness, it inhibits the immune system and reduces inflammation, it inhibits bone formation, it raises the blood glucose level, it increases metabolism, and it supports cardiovascular function, increasing the heart rate, blood pressure, and cardiac output. Cortisol is released in pulses throughout the day and in response to stressful stimuli. It has diurnal variation, meaning that it's high and low at different times of the day. Cortisol typically peaks in the early morning, triggering the person to wake up and get going, and it's at its lowest late in the evening, helping the person to relax and fall asleep. There might be additional spikes throughout the day in response to stressful stimuli. Let's talk about glucocorticoids and mineralocorticoids. There are two types of steroid hormone produced by the adrenal glands. Cortisol, which is a type of glucocorticoid, and aldosterone, which is a type of mineralocorticoid. Glucocorticoids, for example cortisol, help the body to cope with stress, they regulate the immune system, and they reduce inflammation. Medications that act as glucocorticoids include prednisolone, hydrocortisone, and dexamethasone. Mineralocorticoids, for example aldosterone, help regulate the balance of electrolytes and the blood pressure. They act on the nephrons in the kidneys to increase sodium reabsorption from the urine back into the body from the distal tubule, increase potassium secretion from the body into the urine from the distal tubule, and increase hydrogen secretion from the body into the urine from the collecting ducts. They cause more sodium retention and more potassium and hydrogen secretion. When sodium is reabsorbed in the kidneys, water will follow it by osmosis. This means that more fluid is retained within the body. This leads to an increased intravascular volume, or the volume of fluid within the blood vessels, which increases the blood pressure. Therefore, aldosterone and mineralocorticoids work to increase the blood pressure. Fludrocortisone is a mineralocorticoid medication used to replace aldosterone in patients with adrenal insufficiency, where aldosterone is low. It's also used to treat postural hypotension, which is a low blood pressure on standing up, as it helps to increase and maintain the blood pressure in these patients. Let's go through the hypothalamic pituitary adrenal axis. Cortisol is controlled by two structures in the brain called the hypothalamus and the pituitary gland, specifically the anterior part of the pituitary. This is called the hypothalamic pituitary adrenal axis, or the HPA axis. The hypothalamus releases corticotropin-releasing hormone, or CRH. CRH stimulates the anterior pituitary to release adrenocorticotropic hormone, or ACTH. ACTH stimulates the adrenal glands to release cortisol. Cortisol travels off to the body tissues to carry out its effects. It also travels back to the brain and has a suppressing effect on the hypothalamus and the pituitary. This is called negative feedback. Cortisol suppresses the release of CRH and ACTH, helping to keep the cortisol levels within normal limits. When the cortisol level gets too high, it suppresses the secretion of CRH and ACTH. Lower CRH and lower ACTH results in less adrenal gland stimulation and less cortisol secretion, returning the cortisol levels back to normal. An example of negative feedback in action is when we give patients glucocorticoid steroid medications, such as prednisolone, for an extended period. The prednisolone acts on the hypothalamus and pituitary like cortisol, suppressing the release of CRH and ACTH. There are very low levels of CRH and ACTH with very little stimulation of the adrenal glands, and the adrenals stop producing cortisol. In this way, extended use of exogenous steroids, meaning steroids originating outside the body, such as prednisolone, shuts down the production of endogenous steroids, meaning steroids originating inside the body. The body cannot function without glucocorticoids. Since the body is not producing steroids naturally, the patient becomes entirely dependent on the steroids that they're taking every day. Suddenly stopping the steroids can be dangerous, leading to life-threatening adrenal crisis with insufficient glucocorticoids in the body. This means that steroid medications need to be slowly reduced to give the body time to restart the natural production of glucocorticoids. When the cortisol levels get too low, there is less suppression of CRH and ACTH, resulting in more CRH and ACTH secretion, more adrenal stimulation, and more cortisol secretion, bringing the levels back up. Next, let's talk about Cushing's syndrome. Excessive glucocorticoids, or cortisol, leads to Cushing's syndrome. You can remember the causes of Cushing's syndrome with the CAPE mnemonic. C is for Cushing's disease, which is a pituitary adenoma or hormone-secreting tumour of the pituitary, releasing excessive ACTH, which in turn stimulates the adrenals to release excessive cortisol. A is for an adrenal adenoma, which is an adrenal tumour secreting excessive cortisol. P is for paraneoplastic syndrome, for example, ectopic ACTH secreted by a small cell lung cancer tumour. This ectopic ACTH stimulates the adrenal glands to release excessive cortisol. E is for exogenous steroids, meaning patients that are taking long-term corticosteroids at a higher dose. A Tom tip for you, Cushing's disease refers to a specific scenario where a pituitary adenoma releases excessive ACTH. The ACTH stimulates the release of excessive cortisol by the adrenal glands, causing Cushing syndrome. Therefore, Cushing's disease causes Cushing's syndrome. However, Cushing's syndrome has other causes as well as Cushing's disease. The distinction between Cushing's disease and Cushing's syndrome is worth remembering. Cushing's syndrome results in typical symptoms and signs of a round face, sometimes called a moon face, central obesity, abdominal striae or stretch marks on the abdomen, an enlarged fat pad on the upper back, which is sometimes called a buffalo hump, proximal limb muscle wasting, which causes thin arms and legs, and difficulty standing from a sitting position without using their arms to help, male pattern facial hair in women, which is called hirsutism, easy bruising and poor skin healing, insomnia or difficulty sleeping, and anxiety and depression. Metabolic effects of too much cortisol and Cushing's syndrome include hypertension or high blood pressure, cardiac hypertrophy or growth of the heart muscle, type 2 diabetes, dyslipidemia with a raised cholesterol and raised triglycerides, and osteoporosis with reduced bone mineral density. Next, let's talk about adrenal insufficiency. Inadequate cortisol is referred to as adrenal insufficiency. Adrenal insufficiency is potentially life-threatening. Adrenal insufficiency presents with potential symptoms of fatigue, muscle weakness, muscle cramps, dizziness and fainting due to low blood pressure, thirst and craving salt, weight loss, abdominal pain, depression, and reduced libido. Signs of adrenal insufficiency on examination include bronze hyperpigmentation of the skin, particularly in the skin creases on the palms of the hands, in scars on the lips and the buccal mucosa inside the cheek, and hypotension or low blood pressure, particularly postural hypotension, with a drop in blood pressure of more than 20 millimeters of mercury on standing. A Tom tip for you: a high level of ACTH causes skin pigmentation by stimulating melanocytes in the skin to produce melanin, similar to the action of melanocyte-stimulating hormone. Increased skin pigmentation is a sign of Cushing's disease, where excessive ACTH comes from a pituitary adenoma, and of primary adrenal insufficiency, where there is inadequate cortisol from the adrenals with a lack of negative feedback on the pituitary, leading to high ACTH. Addison's disease refers specifically to when the adrenal glands have been damaged, resulting in reduced cortisol and aldosterone secretion. This is called primary adrenal insufficiency. It's primary as the problem is with the direct source of cortisol, the adrenal glands. The most common cause of Addison's disease is autoimmune, where the immune system gets confused and inappropriately attacks and damages the adrenal glands. Low cortisol means reduced negative feedback on the hypothalamus and pituitary, leading to increased CRH and ACTH. Secondary adrenal insufficiency occurs where inadequate ACTH is produced by the pituitary gland, for example after surgical removal of the pituitary or damage to the pituitary. Inadequate ACTH means low adrenal stimulation and insufficient cortisol release. It is secondary as the problem is one step back from the adrenal glands. Tertiary adrenal insufficiency occurs when the hypothalamus produces inadequate CRH, usually due to suppression by exogenous glucocorticoids, for example, long-term treatment with prednisolone. Inadequate CRH and ACTH mean low adrenal stimulation and reduced cortisol secretion. It is tertiary as the problem is two steps back from the adrenal glands. Adrenal crisis, also known as Addisonian crisis, describes an acute presentation of severe adrenal insufficiency, where the absence of steroid hormones leads to a life-threatening emergency. It presents with reduced consciousness, hypotension or a low blood pressure, hypoglycemia or a low blood glucose level, and hyponatremia or a low sodium, and hyperkalemia or a high potassium. Treatment of adrenal crisis includes emergency administration of intramuscular or intravenous hydrocortisone. Next, let's talk about testing. Cortisol and ACTH can be tested on a blood sample. A single cortisol result is unreliable, as the levels fluctuate significantly throughout the day. There should be a relatively reliable increase in cortisol in the morning. Therefore, taking an early morning cortisol at 8 or 9 a.m. may be used as an initial test for adrenal insufficiency. In adrenal insufficiency, the early morning cortisol may be lower than expected. Dynamic tests involve giving a hormone and seeing how the body responds. The short Synacthen test is used for adrenal insufficiency, and the Dexamethasone suppression test is used for Cushing's syndrome. Let's talk in more detail about the short Synacthen test. The short Synacthen test, also known as the ACTH stimulation test, is used to diagnose primary adrenal insufficiency. It involves giving a dose of Synacthen, which is synthetic ACTH, and monitoring the blood cortisol before and at 30 and 60 minutes after the dose. The synthetic ACTH stimulates healthy adrenal glands to produce cortisol. The cortisol level should at least double. In primary adrenal insufficiency, the damaged and dysfunctional adrenal glands fail to respond to ACTH, so the cortisol levels will not double. Finally, let's talk about the Dexamethasone suppression test. The Dexamethasone suppression test is used to diagnose Cushing's syndrome. It involves giving a dose of dexamethasone, which is a synthetic glucocorticoid, and monitoring what happens to the cortisol levels using blood tests. Dexamethasone causes negative feedback on the hypothalamus and pituitary, reducing the CRH and ACTH output. Lower CRH and ACTH means less stimulation of the adrenal glands and less production of cortisol. A normal response to dexamethasone is suppressed cortisol. In patients with an adrenal adenoma, dexamethasone will have no effect on the amount of cortisol released. The tumor is secreting large amounts of cortisol without requiring stimulation by ACTH. Dexamethasone will suppress the ACTH, but this will have no effect on the cortisol release. In fact, ACTH will already be suppressed by the high cortisol level before dexamethasone is even given. In patients with ectopic ACTH, for example, small cell lung cancer secreting ACTH, dexamethasone will have no effect on how much cortisol is released. It will suppress ACTH released by the pituitary, but there will still be lots of ACTH from elsewhere, for example, the lung cancer tumor, stimulating the adrenal glands to continue releasing lots of cortisol. The initial test in suspected Cushing syndrome is the low-dose dexamethasone suppression test. A low dose of dexamethasone is given. In patients with a pituitary adenoma, a low dose of dexamethasone will not be able to suppress the ACTH release. Therefore, cortisol will not be suppressed. Further testing involves the high-dose dexamethasone suppression test. In patients with a pituitary adenoma, a high dose of dexamethasone is enough to suppress the ACTH, resulting in lower cortisol. So to summarize the baseline ACTH, cortisol results in the low-dose test and cortisol results in the high-dose test. A normal response is a normal ACTH at baseline, a low cortisol after the low-dose test, and a low cortisol after the high-dose test. In an adrenal adenoma, there's a low baseline ACTH as it's suppressed by all the cortisol, and the cortisol is not suppressed on the low-dose test and not suppressed on the high-dose test. In a pituitary adenoma, there's a high baseline ACTH from the pituitary adenoma. The cortisol is not suppressed on the low-dose test, but it is suppressed and is low on the high-dose test. And when there's ectopic ACTH, for example in small cell lung cancer, the baseline ACTH is high, cortisol is not suppressed on the low-dose test and not suppressed on the high-dose test. Research has consistently shown that testing yourself after learning a topic has a powerful effect on how long you retain that information. This is known as the testing effect. Studying and then testing yourself results in longer lasting and stronger recall on that information when tested at a later date, even when compared with additional study sessions. If you're preparing for a medical exam and you're not regularly testing your knowledge and practicing your recall, you're failing to maximize your potential. The Zero to Finals members site contains flashcards, short answer questions, multiple choice questions, and extended matching questions that are purpose-built to supplement the Zero to Finals content, helping you build your internal database of knowledge and take advantage of the powerful testing effect. If you like the Zero to Finals notes, books, videos, and podcasts, then you'll love the members site.